Before approving the minutes, I want to welcome Dr. Stephen Thomas. Dr. Thomas is the director of the Maryland Center for Health Equity in the University of Maryland School of Public Health and also a professor of Health Services Administration at the School of Public Health. An internationally recognized African-American leader in minority health research and community engagement, Dr. Thomas has been a lead investigator of multiple studies investigating racial differences in health outcomes. His research focuses on how to address conditions from which minorities generally face poorer outcomes, such as cardiovascular disease, obesity, and HIV and AIDS. Welcome, Dr. Thomas.
Thank you very much.
Before we begin, I want to note that what had been previously listed as agenda item number 3 regarding a certificate of need application by Seasons Hospice and Palliative Care of Maryland was removed from today's agenda at the applicant's request. So the first agenda item is approval of minutes. Included in your packets are copies of the minutes from the June 19th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval. Second. Any discussion? All in favor? Aye. Any opposed? Minutes are approved. Commissioners, you've received the written updates from our centers. Ben, do you or any of the other center directors have anything you'd like to add?
Thank you, Mr. Chairman. On behalf of the staff, I too would like to welcome Dr. Thomas. We're looking forward to putting him to good work here at the Commission, and I think his research interests really align very well with some of our efforts across a number of different domains here. I wanted to also brief the staff or the Commission on several grants that the staff is currently engaged in. Both of those will be due on Monday. The first grant is one that we are pursuing with CISIO, the Center for Consumer Information and Insurance Oversight at CMS. This grant will continue our work with the MIA in furthering our rate review processes, specifically through further enhancements of the APCD and the development of greater price transparency initiatives. That grant has a value of about $1.2 million. We'd have about a year from grant award to spend that, and it will supplement work that we're already doing on an award that was given to the Commission largely with MIA as a collaborator last year in September. The second is a broader initiative as part of the state innovation model effort. Maryland was one of about 20 states that were awarded testing funds several years ago. The Healthcare Commission, as part of that initiative, convened a work group to develop a plan for launching a practitioner performance measurement system. This past month, CMS the Innovation Center released the announcement that additional testing awards would be made. We, in collaboration with the department, are creating a grant application. The department, the Assistant Secretary for Public Health, taking the lead with MHCC, collaborating heavily on the performance measurement initiative and also providing support on the EHR, HIE initiatives as part of the proposal. We'll hopefully submit a proposal. We will submit a proposal on Monday. I can't tell you the specific total value of this application, but its past applicants have received awards in the range of $45 to $50 million, and our expectation would be that Maryland's application, should it be accepted, would be hopefully in that range as well. Lots of work has gone on to this in the last 3 weeks. I want to recognize our HIE staff, David Sharp and others, who have worked pretty much on an after-hours basis to get this going. And I also want to recognize the folks that have been working on the CISIO grant, the Cycle 4 grant. That's Linda Barniska's team, Srinivas Sridhara, Janet Ennis, and Linda in particular for their work we're confident we're going to do well on both of those applications and look forward to giving you some positive news in September or October. So thank you.
Mr. Chairman, Commissioners, Ben asked me to give you just a quick highlight of what's coming in September. In September, Charmaine Robinson is going to give you a comprehensive report for the 2014 Health Benefit Plan, Commercial Health Benefit Plan Performance Report. And there are several new things this year that have been put in place, and I'll just give you a quick rundown on some of them. We held a focus group this year. In fact, in a way, we held multiple focus groups. There's over a period of 3 months, Charmaine went out and made visits with a number of employers and sat down and had face-to-face interviews with them, asking them to critique the report and how we could improve the report. And we also held a formal focus group that was exceedingly well managed for us over at the UMBC campus, and got good feedback, positive feedback, and some good suggestions for changes, one of which was changing the name of the report so it would be more recognizable for them. And but other than that, what we're doing essentially with the report this year is they have expanded the CAP section, which is how the plan members feel about what they're getting. Added some 6 new measures there. And we've, most importantly, I think, for this year, we piloted last year the product called Relic, which we discussed here in our meeting. And this year it goes public for the first time. So September will be the official release on Relic. And it's a pretty extensive piece. It's 27 pieces long of measurement data. But I think you'll find much of it really quite interesting. It covers the whole gamut of the languages spoken by physicians, how plans use the data, and do they support the needs of their members with limited English. There's just a whole list of things that are related to dealing with issues of disparities in healthcare, especially with minorities. And I think you'll find it very interesting as well. So we look forward to the opportunity in September to go through that with you in some detail, and we're excited about introducing Relic this year for the first time. Thank you.
So for the record, I'm David Sharp. Good afternoon, Commissioners, Mr. Chairman. I have one addition to add to the update. Staff is pleased to report that on Monday, July 21st, the online Advanced Directive Registry, developed by AdVault and integrated with the CRISP Query Portal, will be operational. Through much work of the team here at CRISP and AdVault, this registry will allow consumers to create and maintain their directives through a secure website where healthcare providers participating with CRISP can access the information and identify treatment preferences of the individuals. The website includes the changes suggested by Paul Ballard, Counsel for Health Decisions Policy at the Attorney General's Office. Activities are also underway, which is notable, for the electronic medical records for life-sustaining treatment, also known as MOLST. This prototype has been in the wireframe stage of development for several months, and we're working with CRISP, the state-designated HIE, to try to roll this out more into a test environment by the end of the year. So more to come on MOLST, but it's complementary of the advanced directive. So stay tuned, and staff will keep you updated. Commissioners, Mr. Chairman, this concludes my addition to the update.
We'll move to agenda item number 3. The University of Maryland Shore Regional Health and Hospice of Queen Anne's has filed a request for exemption of Certificate of Need review involving a proposed merger of the Hospice of Queen Anne's and the hospice operations of Chester River Home Care and Hospice. This will take place through an asset purchase agreement. Kevin McDonald, Chief of Certificate of Need, will present the staff recommendation. Kevin?
Good afternoon, and thank you. The controlling regulation in this case is COMAR 1024-0104, which allows for the exemption from Certificate of Need review, a merger or consolidation, if those organizations give the Commission 45 days written notice of their intent to merge or consolidate. And the regulations also direct the Commission to issue a determination of exemption from Certificate of Need review if the Commission finds that the proposed action is in the public interest, is not inconsistent with the state health plan, will result in more efficient and effective delivery of services. In this case, written notice was provided on May 30th, 2014. The current situation is in Kent County, Chester River is authorized as the hospice. In Queen Anne County, both Hospice of Queen Anne and Chester River are currently authorized. If this is approved and when the merger takes place, Hospice of Queen Anne would then become the sole provider of hospice services, and Chester River will surrender its general hospice license and will only provide home health agency services in the future. In terms of our assessment, staff assessment, we do believe that the public interest is served by this consolidation in that there will be economies of scale realized. Although potential choice of hospice care for residents of Queen Anne's County would be reduced, for practical purposes, Chester River has not really been providing services in that county, so there would not be any really reduction of choice. Commission staff believes there's a basis for finding that the proposed consolidation is in the public interest because it creates a larger service area and, again, allows those economies of scale. Hospice of Queen Anne projects that its average daily census would increase from 30 to between 40 and 45 patients as the sole hospice providing care in both jurisdictions. Commission, in terms of consistency with the state health plan, we've reviewed the request for the exemption and find that Hospice of Queen Anne currently provides and will continue to provide the specified services required in the state health plan. And in terms of the criteria for resulting in more efficient and effective healthcare services, again, we believe that economies of scale will be served here. There'll only be the need for one set of administrative overhead, and thus would recommend approval.
Thank you. Before discussion, can I get a motion to exempt from Certificate of Need the merger of Hospice of Queen Anne's and the general hospice operations of Chester River? Second? Any questions or discussion? Nope. All right. All in favor? Aye. Any opposed? You have the exemption. Agenda item number 4 is a certificate of need. College View Center, a comprehensive care facility in Frederick County, operated by Genesis Healthcare and owned by Healthcare Real Estate Investment Trust, has requested a modification to its certificate of need. It seeks Commission approval for an increase in total project cost. Mr. McDonald will present the staff recommendation.
There's been a change. My name is Bill Chen. I'm a health policy analyst. I'll be presenting on behalf of College View. Chairman Daniel, Commissioners. College View Center presents a modification request which seeks approval for capital cost increase on a project approved by the Commission on December 20th, 2012. The Commission granted
College View a CON to construct a 130-bed replacement comprehensive care facility relocating from its current site at 700 Toll House Avenue to a site about 2 miles away in Frederick County. The new facility will combine 119 beds from the existing facility with 11 temporarily delicensed beds acquired from Frederick Memorial Hospital, which has operated these beds as an in-hospital comprehensive care unit. The Commission approved this project at a cost of $19,115,222 and with the stated condition regarding a signed memorandum of understanding on participation with the Maryland Medicaid program. The modification requests authorization to increase total project costs by approximately $1.35 million to $20,466,811, an increase of about 7.1%. The following reasons are given for the cost increase. 1, construction bids that were higher than the pre-bid as well as construction change orders. 2, site preparation costs that involved a greater degree of engineering and fill dirt than originally anticipated. 3, inflated costs for movable equipment and advancements to IT systems. And 4, about $1.05 million in capitalized construction interest caused by project delays. Cash reserves, Genesis Healthcare will fund these additional project costs. With regard to the regulations, there are several issues that require the Commission's approval. They are: 1, a capital cost increase that exceeds the CON approved capital cost of $16,760,000 plus the allowed inflation factor. Using the building cost indices in effect as of June 18, 2014, produces an allowable inflation level of $460,222, far below the project cost increase of $1.35 million. And 2, with regard to COMAR 10-24-01-17C, impermissible modifications, the proposed modification will not change the fundamental nature of the project or the services provided. The total number of beds will remain the same at 130 comprehensive care beds, and the applicant does not need an extension of time to meet the applicable performance requirements. Therefore, College View's modification is permissible. The proposed modification will not have an effect on the Commission-approved CON with respect to cost-effectiveness of alternatives or economic viability. With no change either in location, capacity, or nature of the project, the request will not change the need for or its impact on existing providers. The increase in project costs will not impact the costs and charges or the financial viability of College View after project completion. Genesis Healthcare, the operator of College View, and Healthcare REIT, the owner of the nursing home beds and property, have sufficient financial resources to implement this project. Therefore, staff recommends the Commission approve the proposed modification of the Certificate of Need issued to College View Center, which is docket number 12-10-2336, with the same condition attached to the 2012 CON, which was, at the time of first use review, the College View Center operator shall provide the Commission with a completed MOU with the Maryland Medical Assistance Program, agreeing to maintain the proportion of Medicaid patient days required by Nursing Home Standard COMAR 10-24-08-05A2. I would like to introduce the following College View representatives: Ms. Natalie Holland, who is the Vice President of Operations at Genesis Healthcare; Howard Solins, who is the Counsel; and Andrew Solberg, Consultant. At this time, I'm open for any questions you may have.
First, can I get a motion to approve the modification of the Certificate of Need to adjust for the increase in total project cost? Second? All right, any questions or discussion? All in favor? Aye. Any opposed? Is that Dr. Peralta on the phone?
No, it's Fran Phillips.
Fran, okay. Wanted to make sure we knew who was giving an aye. Okay. Any opposed? Motion carries. Thank you. Agenda item number 5 is the Certificate of Need. Palisades Eye Surgery Center seeks a CON to establish an ambulatory surgical facility with 3 operating rooms in Montgomery County, which will replace its one operating room, physician, outpatient surgery center in the same building. Mr. McDonald will present the staff recommendation.
Thank you. Palisades was established as a one-room outpatient surgical center in 2004 and licensed as a freestanding ambulatory surgical facility and is Medicare certified as such. It proposes to replace itself with a larger facility which would include 3 operating rooms in the same space that it currently occupies in the same building that it currently occupies in Bethesda. It would expand to, this expansion brings it under Certificate of Need regulation. There would be the renovation of 9,178 square feet of currently shelled space, resulting in 3 ORs and 2 non-sterile procedure rooms. The cost of the project is approximately $3.64 million. It would be funded with debt at 93% and the remainder in cash reserves. In terms of the analysis against the state health plan, the one issue that the staff found was the charity care policy. The policy, as proposed, is compliant with the 2-day determination of probable eligibility component, also with the notices, posting of the notices of the policy, as well as the eligibility requirements. However, its plan for promoting financial assistance and increasing charity care to the prescribed average level of such facilities is lacking a little bit of detail, and that we'll address that as a suggested condition. Their historical levels of charity care have been under 1% with a 3-year average of about 0.6%. The current average level is 1.2%, which is the measure that it would be measured against. The plan as proposed speaks of promoting its financial assistance plan to participating physicians, outreach to Medicaid recipients and other uninsured, as well as collaboration with public health agencies and nonprofit organizations. Again, the plan does need a little bit of specificity, and the condition will ask for an updated and more detailed plan before first use. Looking at need, need is well documented. The optimal capacity for ambulatory surgery facilities as defined in the state health plan is 80% of full capacity use. The Palisades is currently operating well above optimal capacity and has been doing such for several years now. Most of the growth is due to a significant increase in participating physicians. It has grown from the initial 5 partners to now 18 surgeons using that facility, many of whom cannot use it as much as they would like to. Quality, the proposed design, staff analysis suggests would have beneficial impacts in that the expansion of capacity would avoid the early morning and late afternoon, early evening cases where fatigue is more of a factor. The ORs will be larger, they'll be in line with current design standards, and the layout of those rooms will be standardized, thus creating the ability to reduce adverse events. Looking at the viability and financial feasibility, this current center has historically operated with a healthy margin. The projections going forward project profitability based on utilization projections that seem to be realistic based on the number of participating surgeons and their projections of activity. Impact on existing providers, there are three facilities that would see a relatively small decline in volume, between 2 and 4.5%. That would be Shady Grove Adventist, Providence Hospital in D.C., and Friendship Ambulatory Surgery Center. In terms of other impacts on the health system at large, there'd be a slight expansion of access to the indigent based on the charity care plan. And thus, Commission staff review finds the Palisades Eye Surgery Center application to become an ambulatory surgery to be in compliance with the applicable criteria and standards. As an ambulatory surgery facility under Maryland law, it will be subject to meeting minimal levels of charity care provision established in the state health plan. And as mentioned earlier, the staff is recommending approval with the condition that prior to first use approval, Rockville Eye Surgery Center will provide an updated and more detailed plan to the Commission, Maryland Healthcare Commission, targeting indigent adults who reside in Montgomery County and qualify for charitable care under the facility's policy, collaborating with Montgomery County public health agencies and nonprofit organizations to better reach indigent adults who reside in Montgomery County and qualify for charitable care under the facility's policy, and promoting scheduling of charity care cases at Palisades by all affiliated physicians and physician practices using those facilities. With us representing the application today are Penelope Williams, the director, Andrew Solberg, consultant, and Howard Solins and Jack Eller, counsels to the applicant.
Quick clarification for any motion. If a certificate of need with these conditions passes and the facility does not meet its stated plan, talk to the Commission about the next steps that would usually happen around charity care.
So the question is, if they submit a plan that is acceptable, but then don't deliver on that plan.
Correct.
I think the only recourse is if they come forward with a future application that would mitigate against that application, I would believe.
So no real teeth, if you will.
So before, we want an expanded plan before they're given first use of the facility, correct?
Correct.
So they have
a more detailed plan.
But in terms of executing on that plan, we won't know until they actually have completed first use, and we have some indication through the ambulatory surgery reports what charity care volume was like in that facility, correct?
Correct.
Right. Any questions or discussion?
Thanks for the presentation. I actually support the application. I had a question about the analysis. And on page 18 of the memorandum, there's the third complete paragraph which talks about Maryland's regulatory posture for easy entry of new small surgical center development, and goes on to say which results in substantial OR capacity, which is often not located and operated for high capacity use because of its fragmentation into many different physician practices and so on. I'm wondering if that's something the Commission needs to look at, because if our regulatory posture is creating things that, by your analysis, probably are not as efficient as they need to be, is that something we should look at? So it's less about the actual application, more about the analysis.
I think that would require legislative action, most likely, in that a decision was made at some time in the past that single-room ORs would not be subject.
So that's my question. The CON really becoming a barrier to what, in this report, is suggesting is a more efficient model of larger OR capacity. So I know it's not something we can do here. I just want to raise it because I found it very interesting.
And I think the idea that one OR facilities are not optimal has been one that the Commission has thought about, given changes in the hospital model itself. I think that it is an opportunity to rethink that whole concept. And clearly, if you look at simply the count of ambulatory surgery centers in Maryland, we rival very large states. If you look at the number of OR, just simply the count, we come back into line, which makes the very point that Maryland is not behaving according to the norm, which is greater consolidation of OR capacity in larger facilities. So I think that is potentially an area that one of our work groups does discuss and look at the possibility. All that said, the ability to own and operate an OR is a deeply held economic right that many physicians would contend that they have. So I would expect there would be differing opinions, to say the least.
Yeah, again, I'm not arguing that we should eliminate the small ones, but why create a barrier if we think if it is an appropriate model to have larger ones? And so, but yeah, I recognize we're not going to settle that here, but thank you.
Other questions or comments, Garrett?
Going back to Dr. Tenio's question, so I know you historically, as part of the CON process, you look at prior charity care averages, which you reported, but do you actually go back to your answer before and look at their prior CON submission, what they said they were going to do, and is that part of the process when you were
as a one-room ambulatory surgery? It was actually a physician-operated surgical center. It was not subject to certificate of need in its initial.
But you would look at that. You would look at prior CON promises as part of your process.
We did, yes, and I think for the 3 prior years it was about 0.6%, whereas the current average is 1.2%, and they have made the commitment to come to that level.
Okay. And just, I know we probably asked this question before, I just forget the answer. They're not including bad debt in charity care, right? It's just pure charity care?
Correct.
Thank you.
I might suggest it's not necessarily a motion, but a suggestion that maybe, if I think about history, there's been a number of these issues that have arisen over the past couple of years. Maybe staff can do is go back to some of those where there have been commitments and kind of present a summary, and then maybe even there's a process to just on the public record get note of how people have done post-commitment, which can provide a little bit more transparency. That's a suggestion, not a motion. But I do see some collective head nodding. All right. Do I get a motion to approve the certificate of need? A second? Second. Any other discussion or comments? All in favor? Aye. Any opposed? The motion carries. You have your CON.
And if I could say briefly, first of all, I want to express a great deal of appreciation to staff, particularly to Paul Parker. This project was very close to not making it on the agenda, which was the 60-day delay with August. And Paul and everyone really extended last-minute extraordinary efforts to get to the agenda. It means a lot in terms of the construction timetable and all the rest. We were deeply grateful for that. The second is I just want to give the Commission the assurance. In the application, the applicant said with respect to charity care, it would not wait to see when approved. They started executing on this as of January 1st, and they've had contact with Project Access through the Primary Care Coalition of Montgomery County and are already working hard on that. And not counting your purpose, there's a great deal of work and eye specialists out of overseas South America. It doesn't count for their purposes, but these are people who really give a lot, and now they're going to continue to do that as a way to count for your purposes. So thank you all very much.
Appreciate the comments. We're certainly committed to trying to streamline the CON process wherever possible. All right. Agenda item number 6 is the state health plan for cardiac surgery and PCI. Eileen Fleck, Chief of Acute Care Policy and Planning, will present a summary of the comments received on the proposed permanent regulations for cardiac surgery and PCI services and present staff recommendations for the adoption of final regulations. Eileen and Paul.
Thank you.
Good afternoon.
Good afternoon.
Dr. Tanio, members of the Commission. For the record, I'm Paul Parker. Just want to make some brief introductory remarks before Eileen gets into the details of our response to this latest set of comments. Today, we've reached a major milestone in a process of adapting CON regulation to the changing medical science of treating coronary artery disease that really dates back to the 1990s and the participation of Maryland hospitals in the first Atlantic Seaport research trials. Based on this research, Maryland adopted a policy in the last decade of allowing primary PCI programs, and by primary PCI, I'm talking about emergency PCI. Those programs we allowed those programs to be developed throughout the state, independent of cardiac surgery, to assure that the maximum number of Maryland patients could benefit from timely availability of this service. More directly, this is a major milestone in work that began in 2011 with two objectives. We wanted to fully adapt MHCC regulatory policies with respect to both PCI and cardiac surgery to the latest findings on the safety of both primary or emergency PCI and elective PCI in non-cardiac surgery hospital settings. And secondly, the recognition that ongoing review of program performance is the best approach to assuring the quality of care and the maintenance of the quality of care in the face of great changes that are occurring in the use of both cardiac surgery and PCI services. These regulations are the first step in implementing the 2012 law changes that firmly establish PCI as a regular clinical service option for hospitals independent of cardiac surgery and outside the realm of research and registration waivers. The 2012 law required a longer process for development and vetting of these regulations than is normally used. A clinical advisory group chaired by nationally recognized experts in PCI and cardiac surgery and composed of leading clinicians from throughout the state of Maryland and from other states was convened in 2012 to initiate work on these regulations. And the regulations incorporate almost all of the advice and recommendations of this group, which completed its work in 2013. The advisory group's work relied heavily on the most current national guidelines for these services developed by medical and surgical specialty associations, and that guidance is reflected in these regulations. Staff took the work of the clinical advisory group and developed a draft state health plan chapter. So that's the first version of the regulations before you today for action, and that was released for informal review and comment last year. We received 24 written comments in response to that draft, and we used those to develop a second iteration of the regulations, which was then forwarded to two General Assembly committees for review, which was a requirement of the 2012 law. That process spanned this year's General Assembly session and was and that General Assembly session related to that legislative committee review produced a new law providing for the use of voluntary program relinquishment authority for cardiac surgery programs, and that aligned with the authority that we already had in place for PCI services, so that was a very positive development. And during the legislative committee review, an extensive three-way dialogue took place between MHCC staff, hospitals, and legislators, and 9 written comments were received that were used to extensively redraft the regulations as proposed rules, which you approved in April of this year. In addition to the major changes in the form or regulatory oversight for cardiac surgery and PCI embodied in these regulations, they also open up the process for considering changes in the system for delivering cardiac surgery. And that's an appropriate corollary to MHCC's new authority to reshape the delivery system on an ongoing basis with the potential for deauthorizing poorly performing programs. In line with a general approach taken in reshaping the state health plan in recent years, we believe that moving away from inflexible docketing rules that freeze the delivery system in place and allow the Commission to consider new alternatives is consistent with the dynamic changes that are taking place in reform of service delivery and payment for services that is occurring today. So as you'll hear from Eileen, we are not proposing substantive changes in the proposed regulations in response to the 6 comments that we received in this last round of review. I want to emphasize that this is not a reflexive rejection of those commenters or the concerns they've raised. However, as I've noted, the long iterative vetting process that's already taken place has already addressed many of the areas of interest addressed by these commenters, and we feel like we've made significant changes in these regulations over the past year that really make it a document that reflects a broad consensus of the industry on the type of regulatory oversight system that we want to use for these services. So it's time to put these regulations into effect so that the Commission can move forward with the work that needs to be done. I want to note specifically that work includes considering the future status of the 5 PCI programs currently limited to providing emergency PCI services. We intend to embark on that very quickly after these regulations become effective, and also setting up the process for ongoing performance review of both cardiac surgery and PCI. So while in some respects this is the culmination of a process, as I emphasized at the beginning of my remarks, it's a milestone, and there are many more miles to travel. Eileen will note in her comments that we'll be assisted on this journey by a standing advisory committee for these specialized services, and this group will be used as a sounding board for consideration of the additional fine-tuning changes that will be inevitable as we embark on this new approach to regulation of cardiac surgery and PCI. So with that, I turn it over to Eileen to go through our specific response to these changes. Thank you.
Thank you. As Paul said, there were 6 organizations that commented: Anne Arundel Medical Center, LifeBridge Health, the Maryland Cardiac Surgery Quality Initiative, MedStar Health, the University of Maryland Medical System, and Washington Adventist Hospital. I'm going to review the comments on the regulation and staff's response using the staff memo as a guide. So if you want to see the additional details in terms of what changes were proposed by these organizations commenting and staff's small changes, then you can go ahead and do that. As described on page 2 of the memo, in the Issues and Policy section of the regulation, .03, Anne Arundel Medical Center suggested that that language be added to clarify that the current assessment that geographic access to cardiac surgery services is not a problem does not preclude a finding that access is a problem, or that access is to a high-value hospital may be advantageous. Anne Arundel Medical Center cited a few factors as the basis for its assertion that access to cardiac surgery may be a problem. Staff recommends no change in response to these comments, not based on an evaluation of the evidence cited by the hospital, but because the Certificate of Need review criteria in the proposed chapter allow an applicant to seek to justify the establishment of cardiac surgery services in whole or in part based on inadequate access. In addition, the Certificate of Need review criteria include evaluating the cost effectiveness of a new or relocated cardiac surgery program. As discussed on page 3 of the memo, in section .04a, Anne Arundel Medical Center requested that additional detail regarding the timing of the review schedule be included. Staff recommends no change in response to this request. Other state health plan chapters do not have the level of detail that they've requested, and we don't seem to have problems. So we will, of course, publish a review schedule once regulations become final. In section .04b, the University of Maryland Medical System proposed a change to the language which describes the circumstances under which closure of a hospital's cardiac surgery program will be considered. Both the language in the proposed regulation and the University of Maryland Medical System's proposed changes are shown on pages 3 and 4 of the memo. Staff recommends no change in response to the comments because we've concluded that the language in the proposed regulation ensures that a hospital will have the opportunity to address deficiencies through a plan of correction before closure is considered. In addition, the changes suggested would severely limit the circumstances under which a program could be closed because of the limited number of performance measures included in the regulation, which the University of Maryland Medical System wanted to very specifically reference. So, for example, if the proposed changes suggested were adopted, we believe that a hospital with a high mortality rate or morbidity rate that fails to improve on those patient outcomes despite implementing a plan of correction would not be required to voluntarily relinquish its Certificate of Need. and staff believes that under those circumstances, the Commission should have the ability to request program closure. In Section .05, which has the Certificate of Need review standards for cardiac surgery programs, staff received comments on 3 of the review standards: impact, need, and financial feasibility. As described on page 4 of the memo, for the impact standard .05A2, the University of Maryland Medical System commented that because cardiac services are interrelated and may be interdependent, an applicant should be required to demonstrate that other providers of cardiac services, rather than just providers of cardiac surgery, will not be negatively affected. Staff recommends no change in response to this comment. We've concluded that it's appropriate to focus on the services directly affected by a new provider of cardiac surgery. LifeBridge Health also commented on the impact standard. It suggested that consideration should be given to the impact of cases directed to hospitals as a result of a relocation, rather than just focusing on the impact of cases directed away from a hospital. It believes that because most hospitals will be on a global budget, there could be negative financial consequences to having additional unexpected cardiac surgery cases directed to its hospital. Staff recommends no change in response to those comments. We've concluded that while there may be a delay in making an adjustment to a hospital's global budget to account for the increase, that the Health Services Cost Review Commission has outlined its clear intent to adjust hospital budgets with changes in market share. With regard to the need standard, .05A6, as described on page 5 of the memo, Anne Arundel Medical Center commented that this standard could be interpreted to mean that an applicant will fail to demonstrate the need for a cardiac surgery program if the number of diagnostic cardiac catheterization procedures at its hospital that results in referrals for surgery is less than 200 cases per year, or if the number of referrals is not an essential part of the need demonstration. Staff recommends no changes in response to this comment. We did remove the quantitative criterion, which was included in an earlier draft, in response to informal comments, including those from Anne Arundel Medical Center. As described on page 6 of the memo, LifeBridge Health commented on the financial feasibility standard. It noted that with the new global budget system for hospitals, it's no longer relevant to look at the financial viability of cardiac surgery services. Staff recommends no change in response to this comment. We've concluded that a hospital's global budget is still informed by the types of services being provided and the costs associated with those services, and so it is still relevant to evaluate how various services contribute to the profitability of a hospital. In section .06, which refers to the criteria for certificates of conformance, staff noticed an incorrect reference in .06A1. The appropriate subsection was described in the text, but the numerical reference was incomplete. So we've shown that correction on page 6 of the memo. In subsection .06B3, which refers to the financial viability criterion for elective PCI services, LifeBridge Health commented that it seems inconsistent with focusing on quality because a primary PCI program may be allowed to add elective PCI programs without meeting the minimum volume requirement if the program will still achieve financial viability. LifeBridge Health suggested that this exception should be limited to rural areas where concerns about access to PCI services may be the most prevalent, or where closure of a primary PCI program would have a negative impact on patient care. Staff recommends no change in response to this comment. We've concluded that the other criterion standards for elective PCI services in the proposed chapter assure that the language does not permit a primary PCI program to easily justify adding elective PCI without meeting the volume requirement. As described on page 7 of the memo, in section .07, which refers to certificates of ongoing performance, the University of Maryland Medical System noted that 3 references in .07A5 referred to paragraphs that did not exist. So we made that correction. From the description, it was clear what was intended. I also want to mention that in 3 other subsections in .07, which pertain to focused reviews, the University of Maryland Medical System and LifeBridge Health both commented that the article "the" should precede the phrase "approved plan of correction" rather than the article "an." Staff recommends no change in response to this comment. we've concluded that the wording in the proposed regulation is appropriate. The University of Maryland Medical System also suggested that auditors performing focused reviews should include 2 physician auditors, and that auditors should not be associated with a hospital that is a direct competitor for the hospital being audited. Staff agrees that it is important that auditors be appropriately qualified and independent, but concludes that the definition of a focused review is sufficient to address the concerns regarding the independence of auditors. In terms of the qualifications of auditors, we have proposed adding language to the definition of a focused review. We would add a sentence to the end of the definition stating that a nurse auditor may evaluate the accuracy of data reporting, and a physician auditor shall evaluate the quality of clinical care. This proposed change is shown on page 8 of the memo. With regard to the data collection that's described in .07b3, I think it's incorrectly referenced in the memo as a performance standard. LifeBridge Health and Maryland Cardiac Surgery Quality Initiative and the University of Maryland Medical System all expressed concerns that staff would attempt to duplicate the analysis performed by the Society of Thoracic Surgeons for hospitals participating in the database. And these organizations were concerned that staff's analysis would potentially be redundant and time-consuming and expensive. The Maryland Cardiac Surgery Quality Initiative proposed that as a compromise alternative that the STS individual hospital reports be used for a period of 1 to 3 years, after which the issue could be revisited. Staff recommends no change in response to these comments. We plan on auditing the data more frequently than the Society of Thoracic Surgeons, and if there is an issue with cases not being reported or information being reported inaccurately, then having access to the patient-level data makes it possible to more readily identify those issues. Staff's primary focus in the first few years of collecting the patient-level STS data will be on evaluating the accuracy of the information, which is important for ensuring that there's a level playing field. And we do not believe that this is redundant with the process of the STS. With regard to the quality standard for certificates of ongoing performance for an elective PCI program, LifeBridge Health commented that semi-annual external review is unduly burdensome and expensive if it will not clearly improve the quality of patient care. It suggested that the idea be considered by the clinical advisory group before including it in the regulation. Staff recommends no change in response to this comment. We previously received comments from the Maryland chapter of the American College of Cardiology and others advocating for quarterly external review. Staff responded to those comments by including a requirement for semi-annual review in the proposed regulation. And we also note that the total number of cases to be reviewed has not changed. It's only the frequency of the external reviews. So staff believes that the semi-annual external review requirement is not unduly burdensome. With regard to section .07c6 and D7, which refer to the standards for physicians to perform PCI services at elective and primary PCI programs, respectively, the University of Maryland Medical System commented that if a physician fails to perform the requisite number of procedures, then there should be an opportunity to develop a plan of correction. LifeBridge Health and the University of Maryland Medical System also commented that it's not consistent to say that a hospital shall develop a plan of correction when deficiencies are identified through a focused review, but to then state in sections .07c6 and D7 that a hospital may be required to develop a plan of correction based on the results of evaluating all of an interventionalist cases, which would only occur if that person falls below the volume threshold of 50 cases annually over a 2-year period. Staff recommends no change in response to these comments. Staff notes that the Commission regulates at the facility level, and it is the hospital's responsibility to evaluate individual physicians and address any concerns identified. As described on page 10 of the memo, in section .08, which describes the utilization projection methodology for cardiac surgery, Anne Arundel Medical Center expressed concern about 2 aspects of the projection. Anne Arundel Medical Center suggested that changes in market share resulting from a new program should be immediately incorporated into assumptions about market share 6 years later. It also commented that changes in the growth rate for cardiac surgery in recent years should be weighted more heavily than changes from 6 years ago, because they believe it would result in more accurate predictions. Staff recommends no change in response to these comments. Staff notes that Anne Arundel Medical Center did not present evidence that weighting a change in the cardiac surgery use rate to favor more recent years would result in more accurate estimates. Based on staff's analysis of historic trends by age group and health planning region for the period 2000 to 2013, staff concludes that its approach in the long run will be more accurate. Staff also notes that the utilization projection for cardiac surgery must be addressed by an applicant, but it is not used to dictate the Commission's actions on a certificate of need. The proposed regulations allow an applicant seeking to establish cardiac services the opportunity to address any perceived deficiencies with the utilization projection as part of the certificate of need review process. In the definition sections, both Anne Arundel Medical Center and MedStar Health commented on the procedure codes included in the definition of cardiac surgery. Anne Arundel Medical Center requested that 5 additional codes be added, and MedStar Health commented that 6 other procedure codes should be included. Staff recommends no changes in response to these comments. We believe that some of the codes may not be appropriate to include, and that in terms of the additional codes, and that while the impact of adding additional codes is expected to be minor, we think it's best that we look at this issue through the Standing Cardiac Advisory Committee that we're expecting to form, and look at this further later on. The last couple things I want to mention are there were some changes to the footnotes. A journal article reference, the name needed to be corrected, and then there were just format changes that were made in several of the other footnotes. And then lastly, in terms of the mathematical formula to correspond to the written text describing the utilization methodology, there's a small correction there. There's a term that refers to the age groups, and there was an additional age group included. It said that there was a 65 to 74 age group and an age 75 and older group, when it should just be ages 65 and older. So that concludes my presentation. I'm happy to answer any questions. And
can I get a motion to approve the final regulations first? Second. Any questions for Eileen or Paul or discussion?
Can you describe just in general terms the membership of the advisory committee and the role that they've played in this? Because I believe they're pretty broadly represented by many of the hospitals that submitted comments here, right?
Are you referring to the clinical advisory group?
The clinical advisory group that helped develop these regulations, and they did review the first set of informal comments, right? They reviewed the informal comments that you received?
No, I wouldn't say that.
Okay.
They put together the report, which we used to inform our development of the regulations, but their work really sort of officially ended with developing that report with the recommendations.
Then what is the role of the new group that you're going to be forming?
The new group will be looking at the implementation of these regulations and issues like should the cardiac surgery codes be altered, and then in terms of external review, what should the requirements be for hospitals to ensure that there's a similar level of rigor, and other issues as they come up.
Thank you.
Are there questions or comments? Seeing none. All in favor? Aye. Any opposed? The health plan regulations carry unanimously.
Thank you.
Thank you. Sure.
So before we go on to the next agenda item, I want to first off thank all of the hospitals and cardiac surgeons and cardiologists that participated in this process. We're looking forward through the implementation of the program to continue to work collaboratively with all the parties. And secondly, I want to note the significant work that went on in the Center for Health Planning over the last 2 years. Paul Parker, Eileen Fleck, Sue Ellen Weidman, our Assistant AG, among others, really have devoted themselves to this initiative for a long, long time. And I think we're really excited as we begin to implement these regulations that we've established a new framework for ongoing oversight of these critical services that perhaps can serve as a model for other high-value services in the state and perhaps in other states as well. So there's a lot of appreciation for all those that participated in this endeavor to this point. Thank you.
We'll move to agenda item number 7. Sarah Orth, Chief of Health Information Technology, will present COMAR 1025-15 for consideration as final regulations that will apply to the state designation of management service organizations. Sarah?
Thank you, Mr. Chairman, and good afternoon, Commissioners. Maryland law enacted in 2009 required the MHCC to designate management service organizations, or MSOs, to offer electronic health record adoption and implementation services to providers. The state designation program began in May 2010, and currently approximately 10 MSOs are state designated. To achieve state designation under the existing program, MSOs must demonstrate national accreditation, which requires compliance with over 94 criteria related to privacy and security, operations, technical performance, and business practices. The proposed regulations were adopted by the Commission at the April 17th meeting, and they contain operational changes intended to enhance the program. The proposed regulations were then published in the May 30th issue of the Maryland Register, and no comments were received during the formal comment period, which concluded on June 30th. Staff recommends that the Commission adopt the proposed replacement regulations as final regulations and condition upon the replacement regulations becoming effective, repeal the existing chapter. If adopted by the Commission, staff plans to incorporate the changes into the program. Existing MSOs would have a grace period to demonstrate compliance with the new requirement, and any new MSO entering the program would have to demonstrate compliance with the new requirements. I'd be happy to answer any questions at this time.
Can I get a motion to approve the final regulations of COMAR 1025-15? And a second. Any questions or comments? Please.
I find it interesting that no comments were received. Was that why would you say? Are people already familiar with it? Is it not a major change? What?
Exactly that. People are already familiar with it. We worked with the state-designated MSO advisory panel for about 12 months to get to this point, so I don't think there were no surprises.
That's the ideal situation.
Yeah.
It's indication. Any other questions or comments? If not, all in favor? Aye. Any opposed? Fran, are you in favor? Left. Okay. Motion carries.
Thank you.
Move to agenda item number 8. Carol Christmeyer, Chief of Long-Term Care Quality Performance, and Avanson Mukura, Program Manager in Hospital Quality and Performance, will present the results from the 2013 and 14 Maryland Healthcare Worker Influenza Vaccinations Initiative in Nursing Homes and Hospital. Carol and team.
Thank you, Chairman Tanio and Commissioners. This is the report on the 2013-2014 influenza vaccination surveys that the Commission does. As you can see from the slide, there are 230 nursing homes, 334 assisted living facilities. They make up the long-term care portion, and 46 hospitals that complete the surveys. The Maryland Hospital Healthcare Worker data was submitted through the CDC National Healthcare Safety Network, the NHSN, which you'll hear more about in a couple of slides. But all 3 surveys include documented vaccinations received or reported during the flu season that began October 1st, 2013 and ended March 31st, 2014. Where is the... How do I advance the slides? I don't see the... Will this do it?
Get a first base at next.
Thank you. This slide shows the 4-year results of the nursing home healthcare worker vaccination rate. The most recent flu rates are to my right, and they are bolded. The average statewide vaccination rate shows another increase from the last year and over all 4 years, reaching not quite 80%. We calculate the top and bottom performing 20% averages so that individual nursing homes can compare their performance to this metric. What is not shown on this slide is the number of nursing homes showing improvement. After the first flu season that's shown on this slide, 2010 to 2011, there were only 8 nursing homes that had between 90 and 100% of staff vaccinated. And this year, 76 nursing homes have achieved that level of vaccination. This slide breaks down the nursing home declinations. There's still 20% of staff that are not vaccinated, about 3% religious reasons, 2.1% medical reasons, and those are in line with the hospital rates and also with national declination rates. You can see that about 6% of the declinations are just no documentation. Those are people who say, I went to my doctor's office, I went to the clinic and got vaccinated but could not produce documentation. And another 12% are outright refusals with reasons like, I got the flu vaccine and got the flu, I don't trust vaccine, and I don't believe I need it. This is the status of the nursing home healthcare worker vaccination policy. And a mandatory policy means that annual influenza vaccine is a condition of employment, and there's some consequence for not receiving the vaccine. A mandatory policy is not required by Maryland state statute or regulation, nor is there a national standard that recommends this. So you can see that about 50% of nursing homes currently do not have a mandatory policy. Part of this is due to the fact that in Maryland, the 2 largest nursing home chains have not yet adopted a policy, a mandatory policy, although some of their individual nursing homes might have one as a corporate policy that hasn't occurred. So how does Maryland do relative to benchmarks? This shows another increase in the number of nursing homes meeting the state stat goal. The state stat goal is 60% or greater of the healthcare workers in the institution received flu vaccine. We also do better than the CDC national estimated rate for healthcare workers in long-term care. CDC estimates the rates using a phone and internet survey, which is completed in November of each year. And typically, their mid-season estimates, which is what this is, increase by about 10% when they do their end-of-season estimates, which are not released until September. So they survey healthcare workers in various settings. These are the ones who answered it, who worked in long-term care. They also estimate healthcare workers in all settings, so this would be all healthcare settings, and that is about 62% for their mid-estimate. And the last bullet relates to the state stat goal again, in that 79% of Maryland nursing homes are now meeting that goal. Turning to assisted living, the rates are lower than nursing homes and show not as great of an increase. We've only been surveying assisted living for 3 years now, and you can see the changes. So about a little over 50% receive vaccination. This is We also ask assisted living and also nursing homes whether they provide vaccination on site, whether it's free, what kind of documentation they provide. And about 50% of the assisted livings do say that they provide it to their staff, and it is on site. And about 60% provide educational materials to help encourage workers to become vaccinated. Finally, the last slide for me, we started the recognition program about 2 years ago. Last year, 7 nursing homes had a 100% rate. This year it's 9, and 35 had gold, the gold recognition, which is 95% or better. And this year it's 54, so you can see how that's increased. In summary, for my part of this presentation, vaccination rates among staff employed in long-term care continue to increase, more so in nursing homes than assisted living. To stimulate further improvement for the upcoming flu season, MHC staff are working with the department to target the 30 or so nursing home providers with unacceptable rates. And another initiative has to do with the Medicaid pay-for-performance program, which includes influenza vaccination as part of the formula that calculates their Medicaid pay-for-performance. And we're going to discuss with them providing greater emphasis on that particular metric in the formula. And we're working also with the DHMH Center for Immunization Prevention and Health Promotion, which has educational materials that they use throughout the state to help target the low-performing performers. Also, finally, as we've done in past years, we've calculated corporate rates and prepared letters to corporate officers urging action to increase the rate. So I will turn it over to Evanson now to talk about the hospital rate.
Thank you very much. Mr. Chairman, Commissioners, in addition to this presentation, we have also provided a document listing the 2013-2014 hospital performance for the hospital care worker immunization for the last flu season. This is the 5th year we are collecting this data, and for the last 4 years we are collecting this data using a survey that was formulated by the HAI committee in 2008. In 2008-2009, we piloted this survey, and from 2009 to 2010, that's when we started collecting this data and publicly reporting it. The survey that was formulated by the HAI committee is the same one that was extended and is being used by the nursing home group, and also it's being used by the ambulatory care centers, and also it's being used by the state of Maryland healthcare facilities to collect their data. In addition to that, last flu season, which is 2013-2014, we moved away from that survey and we started entering that data in the CDC NHSN system. This is the same system that we use to record data on HAI, CLABSI, SSI, and also CDI. There is a couple of differences between in definition between the survey that we were doing in the previous 4 years to what we did in the previous last year, because this is the first time we're using a CDC system. And some of the differences in definition, in one is the difference in the flu season. Before, the flu season used to cover from September 1st to April 15th. That changed last flu season to October 1st to March 31st. In addition to that, the numerator, we included healthcare worker employees, and also we included licensed independent practitioners, as well as students and trainees, and also we included the volunteers as well as other contractors. But I want to note that it's only 26 hospitals that entered the data for other contractors, because that data was not required by CDC definition. As for denominators,
these denominators were all employees that were physically present in a facility for at least 1 day. Moving from what we were doing before, we were entering denominators data for employees who are in the facility for about 30 days. Next slide. This slide outlines the shift in the trend in vaccination rate from 2010 to the last flu season. As you can see, the vaccination rate has increased about 15% from 2010, which was 81%, to about 97% in the last flu season. The state start goal is to achieve about 85%, and in 2010, 21 hospitals were able to do that, and that number has increased to 44. That means there's only 2 hospitals in our state that did not meet that goal in the last flu season. I want also to note in this slide that for the last 4 years, we've been collecting data on mandatory vaccination. In 2010, we had 15 hospitals that reported mandatory vaccination, and that number has increased to 45, meaning it's only 1 hospital that did not report having mandatory vaccination policy, and that hospital is Garrett County Hospital. I want to note that working with Maryland Hospital Association, we were able to encourage hospitals, and that's why the number increased from 15 to 44. So I want to give credit to Maryland Hospital Association working with us to encourage the hospital. Although it's not a requirement to have a mandatory, hospitals are able to accommodate and have mandatory vaccination policy. This slide shows all the different categories that were reported in the last flu season. There are a report on facility employees, anybody who was receiving paycheck from the facility. And in addition to that, the other different categories were licensed independent practitioners, as well as students, trainees and volunteers, and also the other contractor. And like I said before, only 26 hospitals reported data on other contractors because it was not required. It was just voluntary. As you can see at the bottom, all different categories that were reported, everybody was able to achieve at least 95% and above. On this slide, this shows from where we started, that is 2009, 2010 flu season, moving all the way to 2013, 2014 flu season. And vaccination rate was went up from 78 to about 97%, and this is about 20% in increase, which is very tremendous. And I think that's one. Yeah, that's it. At this time, we welcome some questions, comments.
Yeah, just a quick context. So, we've been doing this for a couple of years. I think every time we present it to the commission, there's a little bit of a discussion about the pros and cons of mandatory vaccination, with some people having some differing views. But the thing that strikes me here is that we seem to have a significant uptick in vaccination rates that seems to be accelerating past national trends. Is that true? It's hard to sort of pull that out, but is that a fair characterization?
Yes, that is true.
Okay. Any comments or questions?
So this is good to see. I'll tip my hand in terms of my perspective on this. I think it's great news. I love the Gold Star certification and presenting it that way, because that also states that it is a standard to which we, even if it's not mandatory, we encourage that direction. It made me think, I wonder if we present it this way online, as far as the nursing home report, quality report, and the hospital quality report. And so it would be, I think, really compelling to include. I know the information is in there, but it isn't, at least what I was able to find very quickly. It's in there, but it's not presented as a Gold Star certification. And everybody loves getting a Gold Star, but it also sends a really good message to see a facility facility that has received that Gold Star certification. Similarly, on the hospital guide, in looking up whether the information about staff immunization is listed there, I couldn't find it, although I'm not sure, because it lists to influenza immunization rate and pneumococcal immunization rate, but there's no contextual information. So it doesn't say, is that of staff or is that of patients?
Right.
So it would be great to include both, but then clarify who you're talking about in terms of who received the immunization.
Absolutely. And in fact, you're looking at the guide that's currently there. And in September, we'll be, our plan is to present to you the redesigned guide. I came before you in January. We're making major changes to the functionality and the display of information. And I don't know if you recall, we had like 3 rotating pictures where we were going to have feature topics. We're considering having one, healthcare worker influenza vaccination. So that kind of raises it to that level. And we will have information provided with sort of contextual, with some information that gives the reader, particularly the consumer, a sense of what this means. So we're definitely right on the same page with you with that. I should also mention what will be nice in the future, now that we've moved to the NHSN system, is that we'll be able to compare ourselves as a state to other states. And I really believe that we're probably doing a lot better because we got an early start well before other states, and even the CDC made this a priority. This commission made this a priority. So we're hoping to see some real positive numbers when we compare ourselves.
One other question. I don't know if there's a way to correlate data to see if there is, what the impact is of the immunization rate. Do we see an impact on improved patient health, improved patient outcomes in any ways?
You want to answer that one?
Yes. We tried to look at the data that is provided by the Department of Health and Mental Hygiene, and there's no correlation about that because the last report they had, they were reporting increase in flu activity in our state compared to the previous flu season.
But we haven't tried to compare, and that's the first step we did because we anticipated that question from you also. We're also, we want to look at the vaccination, or at least offering the flu vaccination. That's what that measure does. You have to at least offer the patient the vaccination to see if that measure relates any to what we're seeing here. And then we were going to look to see if there are IC9 codes within the discharge data that tell you whether or not the patient had the flu and if it was present on admission. So there are other ways we can try to get at this, but we haven't been able to at this point.
And if I could just speak to the long-term care, to your comments, we do, and I think you noted, post the individual facility reports on the consumer guide, and I see no reason why we can't put the Gold Star recognition on there. That's a really good idea. I also did some trending looking at influenza outbreaks among nursing homes in Maryland and level of staff vaccination. And we didn't find a strong correlation at all. And we think it's because since 2009, when the H1N1 was new, it's been relatively mild flu seasons in Maryland, and so there haven't been that many outbreaks. And outbreaks are really dependent on local reporting efforts, so it's possible that we're not capturing all of them. And one other point, CDC just published a new report that looked at the relationship of staff and staff outbreaks and morbidity and mortality among long-term care residents, and I will get that for you.
Thank you. Dr. Thomas?
Yeah, just briefly, and you may well have anticipated this question. I'm interested in those refusers at 12%, and you mentioned a couple of the reasons, like don't trust. Well, the question was, do they not trust the vaccine, or they don't trust the agency delivering the vaccine? You may not know the answer, right. But I'm curious there, because that makes a difference. And then, does noncompliance with the vaccine impact workforce capacity? In other words, if I'm a worker and I'm going to refuse to take the flu vaccine, does that affect my ability to work with the patient? Does that affect my work capacity?
Some nursing homes, speaking for nursing homes, do have policies that will require them to wear a mask, might restrict them to certain areas if they might, and it varies because it's a nursing home policy, may require that they not work during the time that they may be symptomatic. So there are various measures that are used.
But that's not standard. Is
not standard.
No standard.
Correct.
And then last but not least, do we have any information on the demographic characteristics of the healthcare workers?
Not as part of this survey, no.
So there's no way to know if there's a difference between Latinos, African-American workers, white workers? No way.
No.
Now, you mentioned new design issues. In the new design, is there an opportunity to include this kind of demographic information?
Through CDC, that information is not collected. We actually get aggregate information.
Do we know anything about the patient population demographics?
We definitely know about the patient population. We can get that through the discharge database.
Thank you.
Michael?
Great report, and I was just, as you were talking, just refamiliarizing myself with some of the literature. You anticipated what I was going to say, and that the literature is pretty mixed, obviously citing most in favor of vaccination, but certainly has strong arguments that have articulated by a lot of different people. So the only thing I ask is that as support this policy, that we keep abreast of the literature and make sure, because the compulsory vaccination of a vaccine that is effective but not 100%, some of the controversy about people defining the morbidity or mortality associated with that in healthcare settings, I think is worthy of continuing to monitor, even as we go in this direction, which I fully support, but I think it's important to acknowledge that there is significant controversy by well-respected. This is not quackery. These are people who really are getting into the epidemiology and the pathogenesis of the influenza and the vaccine itself and its variable effectiveness year to year, and raising some reasonable questions.
It is evolving, and we've seen some of those articles as well. And we've also seen the issue of mandating, requiring employees to take the vaccine. There's, I think, a recent case where the court sided on behalf of the employee. So there are a number of things that are occurring at the same time that we're moving this forward, and we are trying to, because I was hoping that it wouldn't detract from what we're doing, but whatever the science says, it says. So if it evolves to be a little something else, then we have to address that.
Very good.
One question. Do we know who is providing the educational materials that the nursing homes are using or the hospitals are using? Is it the CDC that they're relying on?
We have sent regular communications each flu season and provided links to the CDC educational materials and also the educational materials that DHMH has on their website.
Is there more we could be doing to educate?
Well, that is one of the initiatives that I mentioned with the Center for Immunization and Health Promotion for DHMH. They've provided these educational materials and programs to hospitals and other settings, ambulatory care, and this year they're working with us to promote it among some of the long-term care providers.
So potentially they could look at who receives educational materials and then what their immunization rate would be and if it differs. Thank you.
Garrett?
Excuse me, a couple of questions. First of all, yeah, great job. I think it's fabulous that you're doing this and tracking this for the last couple of years. It was on the hospital slide, but the criteria for who you count in the numerator and denominator, is that the same for the other categories, just living in nursing home?
The numerator and denominator.
Let me go back to this.
Historically, it's been the same. This is the first year we've switched to the CDC definition, which is a bit different. But historically, we've defined the numerator, which is basically the employee.
Mm-hmm.
And that's why we have a larger number of persons vaccinated, because we're now, it's been expanded using the CDC definition. But I don't know.
Obviously, my question is, would that make a difference on the other two categories, nursing home, assisted living, if they use that?
Right, that's what I think. Carol?
Up or down?
The denominator is the same for nursing home and assisted living. The numerator, we did not collect contractors or volunteers. Anyone who received a paid check. Yeah. So that is the same.
Just to be clear.
Okay.
Just to be clear on that.
Yes.
So we don't get lost here. The numerator and denominator for hospitals are actually the same universe. It's the numerator is those that were vaccinated in that denominator universe, and I think it's an abbreviation in that slide that seems to suggest that the numerator is everyone who received a paycheck, and the denominator and other contract workers, they receive and received a vaccine. The denominator is the same, but everyone, regardless of whether they received the vaccine, correct? It wouldn't make sense to have a different universe. So that's an abbreviation, but the potential people in the denominator are then defined in the numerator as to yes or no got the vaccination, correct?
Right. And historically, we excluded the physicians because it was so controversial. But if you vaccinated the physician, you know, you want to get credit for that, then definitely. So, we're really grateful to CDC in expanding that definition because now we're all on the same page.
Okay. Thank you. Dr. Thomas hit a little bit, but are you able to, or have you collected, or do you have any best practices that you could use in terms of add to the education piece? Because, you know, I mean, I go through this, been going through this in the field for 25 years, like many of us, and I'd like to know, you know, especially with the hospitals, how they got up to the higher percentages. So if there's any best practices that you can share, especially with the nursing homes and assisted living that you learned from the hospitals, that would be wonderful. I don't know if you're doing it, and that's the question.
We did in you want to answer that one? In a previous survey, we asked hospitals, what are you doing? What activities are in place? And virtually all the hospitals were providing free vaccination and a number of other sort of incentives, I guess, or opportunities to get the vaccines. But I think what made the difference is that once the hospital administration or leadership decide that this is the way they want to go, they want to support a mandatory policy, then all of a sudden we saw the numbers change. And that, I think, is in part due to the fact that we publicly report this information. And if no one else, the hospitals are using the hospital guide to look at themselves and look at their other, look at the other hospitals.
Okay, thank you.
I don't know if you want to speak to nursing homes.
Yeah.
Well, yes, 2 years ago, we held a webinar with a large healthcare system in St. Louis that had implemented a mandatory policy of, they have a number of hospitals, nursing homes, ambulatory care centers, and they talked about the best practices. And so that webinar, there were a number of nursing homes in Maryland who participated in it. We've made it available on the website, and we've continuously communicated those sorts of things to them. Obviously, a mandatory policy is a real incentive, but there are some other things which nursing homes report to me that they're using. So, but I'm not sure how, how widespread it is.
Okay, thank you. Also, and I'll go quick, I'm sorry. The 334 assisted livings, we see this number from 0 to 5,000 assisted livings in Maryland. I wonder where you got the 334 from, or is it over a certain amount of beds?
For assisted living, yes, it is. Thank you. 10 beds or more are the assisted living.
Okay. And the last question is just a comment which I've talked about many times here. Another clear example of if you measure it and publish it, so maybe the hospitals are looking at it on their own, things get fixed. So it's, again, my ongoing point that there should be tougher hospital quality indicators that can be public to help improve some of the hospital quality indicators like the nursing home quality indicators. This is just another example of once it's published, they're going to get the numbers better. Sorry.
Appreciate the rich discussion. What we're going to do is after adjournment, we're going to take about a 5-minute break and then reconvene for working sessions in this room and in room 101. Then which one is which in terms of?
I think we'll keep with the configuration we had last time, which is the PCMH group was in the meeting, the 101, and the CON group will meet in this room.
Okay.
I did want to just, before we break, say that give the commission set the state stat standards that we were aiming to meet, the goals of 85% of hospital workers vaccinated. So I think we will be coming back to you with a recommendation on what we ought to tell the governor's office in terms of our next goal. Clearly, with hospital workers, we're sort of topping out at above 96%, and it may be something that we want to select as another state stat measure. We still want to deal with the workers, and I think we understanding why there is variability and what types of facilities and where facilities are located would be key discriminators to know about in future reports, particularly on the nursing home and assisted living side. Why there's some high, some low. What are the characteristics? What types of patient populations are high and low performing facilities treating? Would give us some additional clarity on what might need to be done.
If there's no further business before the Commission, I'll entertain a motion to adjourn. Second? All in favor? Meeting adjourned.